It's a real pleasure to join you here. And I thank Professor Khanna for his very kind invitation. And well, we can recognize how humanity is something fantastic, joining technology and will to patients through this pandemic. And despite virus and all problems, we're able to share now. I think we collectively be very proud of that. And of course, I want to thank the commitment of Professor Khanna to be able to go through this pandemic and nevertheless have the exchange possible now. So I'm going to present you something quite out of the box from the general intervention field so far, but I think it's very important for us to realize that erectile dysfunction is something very important and that most of this pathology relies to vascular problems. As a human problem, it is something very important. Just consider that young guys between 20 years old can have no erection for 5% of them. Can you realize that? This is nearly unknown, and this is something that appears to epidemiological studies. And what is at stake there? It is a social burden, it is a cause of suicide, and it's probably one cause of young male overmortality. Of course, the pharmacology has been very helpful and has been a revolution, but we have to realize that 30% of patients resist to this oral pharmacology for erectile dysfunction. And it turns out that cavernovenous leakage is the main cause of failure of medications in severe erectile dysfunction. You see on the left part a bath tube represented the cavernozoa, and the idea is that for having strong erection, one needs to fill up the bath tube with blood, and this is the function of arteries. But of course, for the bath tube to be filled up, one needs the blood to stay into the cavernozoa. So you need to have a blockade of blood exit for the duration of erection. If this doesn't occur, of course, erection cannot take place. And this is the field of venous leakages, because blood erases from the cavernozoa through these leakages. If you look at the mechanisms causing severe erectile dysfunction in resistant to medical treatment, if you do a duplex scanner, we'll go back to this in a few minutes, then you see that half of patients with erectile dysfunction resistant to medical treatment have cavernosa leakage. So if you go back into the literature, and of course urologists are on top of this, you see that urologists consider worldwide that any surgical or interventional treatment shouldn't be performed for these venous leakages because they are all inefficient. And so the patients are proposed penile implant, not of course if they are 20. So it means that young patients in particular are left without any clinical option, without any treatment, which is a drama. So we went back to this literature and we decided to start a program to improve previous results. And so we've decided to associate during the same procedure both open microsurgery to ligate the veins and embolization to treat cavernovenous leakages. So the basis of our approach was this one operative approach. The other was a very accurate preoperative diagnosis using duplex sonography and also a preoperative venous cartography with cavernous scanner. And of course, we did a very precise follow-up of patients with, on a clinical standpoint, and with duplex sonography. I want to spend just 1 minute on duplex sonography because I think there is very many, unfortunately, misleading information in the literature. It is the diagnostic tool that should be used for any drug-resistant erectile dysfunction. It has to use a standardized protocol of intrapenile injection to induce erection. And we now propose 80 milligram of intracavernous papaverine, which is huge. You shouldn't inject that to any patient without being sure that he has severe erectile dysfunction. Otherwise, you would have troubles. The first criteria is limp penis, despite high volume of high level of injection of pharmacological stimulation. In itself, this is a very important diagnosis step. The second step is the arterial evaluation, and the end diastolic velocity persisting over 5 centimeters per second is a criteria for diagnosing cavernovenous leakage. But the other point, and it is very important, is to concentrate also to the hemodynamic analysis of vein draining the penis, and in particular the deep dorsal vein. So we have included 45 patients with long-lasting drug-resistant erectile dysfunction with no, and this is very important, no significant arterial or neurological disease, no urological penile disease, no previous penile surgery, and who refused prosthesis implantation. And this is the population of the patients. Just consider the age of those patients. It's a huge range from 20 to 68-year-old patients. And also 17% of them are diabetic patients. Now, regarding their erectile function, 90% of those patients were unable to have any efficient erection, allowing sexual intercourse, despite all drugs on earth, including injections, and 10% of them would be able to have intercourses with penetration, but with intracavernous injections of EDEX, for instance. So this is, these are images of preoperative, postoperative cavernoscanner. Scanner. The principle is that you inject into the penile shaft papaverine as for duplex scanner. And you see on the left part of the screen a normal answer with a very strong erection after treatment. So this is what normality would look like. And in the center, you see a forest of veins because you also inject into the penis contrast medium. And you see with the green arrow, the deep dorsal vein leaking, and also this is the red arrows, the superficial abnormal drainage into the iliac veins. And you can see also with this examination very precise images of what's going on into the penis drainage. You see on bottom top, for instance, you see opacification of the spongious corpus, which is abnormal. And you see duplication of the deep dorsal vein, which is to be considered for surgery. These are other anomalies. You see on the left here, what I call a plexiform dystrophy of veins at the surface of the penis. And you see the operative view on bottom. And on the right panel, you see a huge, like varicose aspect of the periprostatic venous plexus, which means that this gentleman has a huge flow going through this plexus as a leak. So it would be hard to have strong erections with that. So back to this technique again, it's endo and embolization and open surgery associated during the same procedure. It's a long procedure. It takes 3 to 5 hours to do it. Embolization is a very important step, and we're lucky to work with an hybrid room. And at the end of every procedure, we do injection into the cavernozoa, and you see 2 examples of remaining leaks that you can deal with before awaken the patient. So with this control, you're quite pretty sure that you go through any vein that would provoke leakage in those patients. So this is a view before and after the surgery. You see, this is the right arrow. You see the disappearance of a deep leakage circus from the deep venous vein after surgery. And you see no erection, whereas you see erections afterwards. So if you go into numbers, any patient had a 3 months post-operative assessment by pharmacological stimulation and duplex scanner, and you see EHS stands for erection hardness score, and you see, just remember the 3 is the minimum to have penetration skills in terms of strengths of erections, and that the medium EHS progressed after surgery. There was no change in end diastolic velocity for any reason, but of course there is a disappearance of any velocity on deep vein after the surgery. This is a 14 months follow-up. 5 patients required reoperation for recurring leakages, and the results of those 5 additional operations are summarized in the secondary success rate. 3 patients had prosthesis implantations, which means that this surgery doesn't preclude any other possibility of treatment for erectile dysfunction. And I just want to stress on the last line here. Remember that only 10% of patients could have sexual relationships with penetration, but with intracavernous drug injection. And you can see that in terms of primary success, they were 37%, and after secondary operation, a total of nearly 82% patients were able to have sexual intercourses with penetration. Just a word regarding diabetic patients. Erection dysfunction in diabetic patients is the pile of different mechanisms ranging from neurological, arterial, venous, microvascular, endothelial dysfunction, etc. But we've been able to, in fact, to provide a quite efficient solution to those diabetic patients, as efficient as non-diabetic patients, but after elimination of neurological patients and arterial patients, which means that any patient with diabetes and erectile dysfunction resistant to treatment should have duplex scanner to identify venous leak. And finally, this is a patient who called me 2 weeks ago, is going to be a father. He had operation 8 months ago. And that's, I think this is the human dimension of this surgery. So as a summary, this surgery allows 80% patients to perform penetration after 14 months, 1/3 with no medication. Pre-diagnosis, preoperative diagnosis, and anatomic assessment are keys, as well as extensive venous blockage. Thank you for listening.
Thank you very much. That was wonderful. Maybe if Dr. Taneja and Dr. Saxena permit, then I may present my presentation on arterial inflow issues, and then we can have a good discussion.
Yes, no needs.